Welcome to this video on the mechanics of coding. We are exploring how your documentation transforms into essential clinical data, including DRGs, severity, and risk scores. We'll examine the vocabulary coders use, the rules for making a diagnosis codable, and the best ways to document your assessment and plan to accurately reflect your patients. Your documentation flows into three key areas that represent your patient: payment, which is driven by the principal diagnosis and DRG; severity, which is determined by comorbidities impacting illness and mortality risk; and long-term health tracking through risk scores. Accurate documentation ensures these data points correctly capture the acuity of your patients. Let's cover the DRG engine. A DRG, or diagnosis-related group, categorizes conditions by resource needs. Each DRG has a weight, a calculated resource consumption value, and a GMLOS, or geometric mean length of stay. Comparing this to the patient's actual length of stay, or ALOS, helps determine the efficiency of the hospital visit. Key diagnostic terms define the visit. The PDX, or principal diagnosis, is the condition primarily responsible for admission and drives the DRG. POA, or present on admission, asks if the patient arrived with a condition. Secondary diagnoses include relevant, managed conditions, which are vital for capturing the true severity of the patient's illness. Capturing patient acuity relies on identifying comorbid conditions. ACC requires more resources to manage, while an MCC, or major comorbid condition, requires even more. These impact the SOI, or severity of illness, and the ROM, or risk of mortality. Documenting these conditions accurately reflects the patient's actual clinical needs. HCCs, or hierarchical condition categories, affect a patient's long-term health risk. Each qualified diagnosis has an assigned score, which CMS uses to calculate the patient's RAF, or risk adjustment factor. It is vital to document chronic conditions annually, or they will disappear from the patient's risk profile in subsequent years. The golden rule for coding is simple. A diagnosis must be established, relevant, and consistently documented. It must be confirmed by clinical data, managed during the visit, and tracked across your notes. Missing any of these elements can prevent the diagnosis from being captured, resulting in incomplete patient data. To establish a diagnosis, show your work. Support it with clinical findings like vitals, labs, imaging, or specific diagnostic criteria. For example, documenting sepsis with specific SIRS criteria and the source of infection demonstrates that the diagnosis is supported, moving it from a suspicion to an established, codable fact. A diagnosis is relevant when you actively manage it. This includes monitoring or supportive care. Tie it to the visit by documenting your management, such as ordering tests or monitoring labs. Clear documentation of how you are addressing a condition ensures that it is recognized as a relevant part of the patient's care. Consistency is critical. A diagnosis should appear across the chart from the H&P to the discharge summary. Update the status daily to reflect the patient's progress. This thread of documentation ensures that a condition is tracked throughout the stay and is accurately accounted for at the time of discharge. Codable diagnoses live in the assessment and plan. Clinical findings like labs and physical exams support your diagnosis, but they are not codable on their own. Always ensure your diagnosis is explicitly stated within the assessment and plan section to guarantee it is captured for coding and quality purposes. One recommended way to format the assessment and plan is the inline approach. Use one line per diagnosis, including the diagnosis itself, the supporting clinical data, and the management plan. Update this daily to reflect the patient's current status and changing clinical picture while maintaining a clear, compact record. Alternatively, you can use the stacked format, which groups each diagnosis into its own mini-block. Start with the diagnosis, list the criteria or support below it, and add the management plan. This format allows you to easily include daily status updates within the same structure for each active condition. Regarding uncertain wording, possible, likely, or suspected diagnoses are often codable if they are supported, managed, and consistently documented. However, do not use rule-in or rule-out language, as these are not codable until a definitive decision is made. Commit to a working diagnosis to ensure proper coding. Finally, be clear about how diagnoses relate. Phrases like "in the setting of" can be ambiguous. Clarify whether one condition caused the other, or if they coexist. For postoperative conditions, specify if they are complications or simply postoperative. Clarity in these relationships prevents miscoding and ensures accurate documentation. Let's lock in these 5 habits for documentation that counts. 1. Always state the diagnosis in your assessment and plan. 2. Make it established and relevant by showing your management. 3. Keep it consistent until discharge. 4. Capture severity and risk by naming comorbidities. 5. Clarify uncertainty and relationships. Mastering these 5 habits ensures your record accurately reflects your patients.